Um, Thanks for joining us today for talking about navigating the perinatal journey, mental wellness tools for every step. This December 2025, I'm Christine Cole. I use she, her pronouns, and I work at the Healthcare Authority. I am fortunate enough to just be here to kind of be the guide and coordinator. I'm joined by two of my colleagues, one from the Perk Center and one from Department of Health, who are going to also share content, and they will introduce themselves when it gets to their part. And we're really glad that all of you are joining us to talk about perinatal behavioral health today. Uh, what you can expect from our time together, we're just going to spend a little bit of time going over kind of the background of why we're having this presentation and how we got here. Then my friend Deb is going to talk to us about the maternal mortality review panel findings, which were just released this morning. My other Deb is going to talk to us about perinatal mental health toolkits and how they can be used in your communities. And then hoping we have some time to talk about available resources for you all at the end. So to just set the stage, there are a lot of babies that are born in Washington each year, which means we have a lot of perinatal people in our state. On average, about 20% of our new and expecting parents are impacted by perinatal depression or related mood and anxiety disorders. And so that's a lot of folks. We know that poor perinatal mental health is associated with adverse outcomes. And so this is an opportunity of impact, but it also is an opportunity for us to be able to support and to help folks out. Postpartum depression has been deemed one of the greatest risk factors for maternal suicide, which is a really big impact on maternal mortality, which is why we're going to talk a little bit about that today. And that we know that it's not just the people impact, which is very important to us, but we also like to highlight that there's a fiscal impact to these choices because we know that's important for folks who are thinking about policies and financing as well. And so this is just to highlight that perinatal mental health actually impacts a lot of folks nationally, but in our state, and that us understanding those impacts can really make a difference in the well-being of children and their families, but also of the health and well-being of our state as a whole. The reason we got here, we were really fortunate. There's a group in North Carolina who put together these toolkits, tailored supports and resources looking at different things that impact individuals during the perinatal period. And we had some colleagues over at the First Step Family Support Center over on the Olympic Peninsula who said these are really great toolkits. It would be lovely if we could have them in Washington State with our own resources and supports tailored to our communities. In particular, Allison Williams is someone that I think we should just say thank you and give a huge shout out that she said, why can't we have these in our state? And her colleague, Alicia Anderson, reached out and we were able to partner across the University of Washington, Department of Health, the Department of Children, Youth and Families, and the Healthcare Authority to update these toolkits to make them relevant for Washington State and aligned with our resources that we have available. So we were lucky that we have partners who are looking out to support perinatal people. What that resulted in is we just took the toolkits that they already have available and we tailored them for Washington. So there are toolkits that touch on anxiety and depression, integration of behavioral health care in primary care, ADHD during the perinatal period, maternal sleep and well-being, and then also talking about maternal suicide and risk assessment. I think this is my last slide before I hand it over, and so I'll just do a little bit more talking and then hand it to Deb. The reason that we are starting with the maternal mortality review panel is to really set the stage to go deeper into some of those statistics that we talked about the ways in which perinatal behavioral health impacts our communities in Washington. And while that content can be hard to hold, the impact that we know that families are experiencing. We also then wanted to tailor it by offering these tools and resources available to our communities as ways that we can all take steps to support perinatal people, even in the midst of knowing that we have a lot of growth and a lot of challenges that we need to overcome. And so with that, I will hand it over to Deb to talk about our maternal mortality review panel. And I'm going to stop sharing my screen.
So much. I'll get our slides up here. Great. Yeah, thank you so much for the opportunity to present. We are very excited that the Maternal Mortality Review Panel report, the 2025 report, actually just went to the legislature last week, and our news release just went out about it this morning. So this is very exciting timing. So I'm going to give you just a little bit of background about the report's findings as relevant. There's a whole lot more detail we could go into. If anybody wants to contact me for a longer presentation, I'm happy to do that. This is a QR code where you can get to the report. And if one of my colleagues doesn't mind dropping the link for the report PDF into the chat, that would be great. If not, I will do that as soon as I finish this. But like I said, this just went to the legislature. The aims of the report are to prevent maternal deaths, raise awareness about contributing factors to those deaths, to promote change, increase health equity, and improve perinatal care across the state. This new report includes data from 2021 and 2022 maternal deaths, and then also some cumulative findings from 2014 through 2022. And there are recommendations in the report for both the legislature and other audiences, as well as an addendum from the American Indian Health Commission. Just a quick overview of some definitions we use a lot in the report. We talk about pregnancy-associated deaths, meaning the sort of large umbrella term of any death that happens for any reason from any cause that happens to be during pregnancy or up to 1 year after the end of pregnancy, regardless of whether the death was related to pregnancy. And so a subset of that are the pregnancy-related deaths, the ones that were caused or worsened by pregnancy. So these happened because of either a pregnancy complication, a chain of events that was initiated by pregnancy, or even a totally unrelated condition that was aggravated in some way by some aspect of pregnancy. And then some of the deaths that the Maternal Mortality Review Panel reviews are not pregnancy related. And then sometimes even the panel cannot determine, they don't have enough information to determine whether it was related to pregnancy. I'm only going to give you a couple little points of data here, and then otherwise some broad overviews, just in the interest of time. But I just wanted to show here that maternal mortality rate increased in Washington state in 2021 and 2022. So I was just talking about pregnancy-associated deaths, that umbrella term, and then the pregnancy-related and not pregnancy-related deaths. So the dark line that you see at the top there, that's the pregnancy-associated deaths. So you can see overall in those last 2 years, 2021 and 2022, those increased. And then the dashed lines below them add up to them. The green ones are the pregnancy-related deaths, and the light blue are pregnancy-associated but not related. And you can see that those also increased in 2021 and 2022. And then I also just wanted to show that specifically pregnancy-related behavioral health fatalities increased in 2021 and 2022 from previous years. So pregnancy-related behavioral deaths, including by overdose, suicide, and homicide, were increasing in Washington as of these most recent years that we have data on. And the majority of these deaths are due to drug overdoses, 74%. Most of those overdoses involved fentanyl, 76%. So just some key overview messages from the report. Like I mentioned, maternal mortality increased in these years. You saw those rates went up, so that that rate of 30.5 per 100,000 live births was statistically significantly higher than the state's rate in 2017 through 2020. Most pregnancy-related deaths, 82%, were preventable. This is similar to what we found in the last report. And it means that we know what's necessary to save lives and to take action. And then behavioral health related deaths were the leading cause, accounting for nearly 45%, nearly half, 45% of all pregnancy related deaths. The panel identified discrimination, bias, interpersonal racism, or structural racism in 76% of the preventable pregnancy related deaths in these 2 years. And that does include bias about substance use disorder or substance use. Disparities and inequities persisted, as we saw in the previous report, and we saw them along lines of age, race, and ethnicity, which relates to that structural and institutional and interpersonal discrimination that we were talking about. And that's particularly for American Indian and Alaska Native communities in Washington. Also, we saw disparities along lines of rural residency and Medicaid coverage, which of course is a reflector of socioeconomic status and related factors. I mentioned that the panel found 82% of pregnancy-related deaths were preventable, and just want to emphasize that this does reflect the panel's broad understanding of preventability. Our MMRP doesn't just ask whether something was clinically preventable, but were there equity or social determinants of health factors that could have prevented the death as well. So I just wanted to show you the timing of pregnancy-related deaths in this 2-year period too, because something that really jumps out is that in this 2-year period, most of the deaths happened in the postpartum period. So this is broken out between the 8% who died during pregnancy, 14% who died the same day as delivery, 29% who died in the first period of postpartum through 42 days, and then 49%, nearly half of all of the pregnancy-related deaths, who died between 43 days postpartum and a year postpartum. So this really shows, these exact numbers can fluctuate between years. We're looking at small numbers, so rates can be very unstable. But the key message from this is that postpartum period, including later postpartum, is really important. And the reason it's especially important in this presentation is that this is especially true in these behavioral health deaths. So 82%, even higher, of the pregnancy-related deaths that were due to unintentional overdose occurred between 43 days and 1 year after the end of pregnancy. So we really need to pay attention to that later postpartum period and underscore the importance of care, support, and health insurance coverage through a year postpartum. So let's talk about recommendations from the report a second. The report includes 3 overarching priority recommendations, and under those, there's a lot of very specific sub-recommendations. There's 12 recommendations for the legislature, and there's 75 recommendations for other audiences, including some of the examples on the screen as well as others. The report this year, which is shorter than our 2023 report, divides things out a little bit more. We want to make sure the legislature understands that they are the key audience of this report and things are a little bit more focused. And then there's a section that follows the legislative recommendations with all the recommendations for other audiences. So those 3 priority recommendations are to improve healthcare quality and access, to strengthen community support services, and to provide equitable, culturally responsive care. So let's look in detail at this improving healthcare quality and access recommendation. This is just, again, overarching that we should ensure Washingtonians have access to high quality healthcare, which includes mental health care and substance use disorder treatment, as well as preventive care. This should be throughout pregnancy, birth, and postpartum. And to do this by strengthening and funding things like care coordination, improving communication and protocols, and ensuring that providers have what they need, the skills and the training and professional support to provide high quality care. Like I mentioned, there are over 80 recommendations in the report, over 90 recommendations in the report. So I'm just going to give you a couple examples from each category. And even these are, some of them are shortened versions of what's in the report. So do look at the report itself to see what all of the recommendations are, in case you're wondering, well, why isn't there one about this? This is just 4 examples from the first category. But things like providers should establish collaborative care or team-based models of care that ensure coordination of behavioral health care across the perinatal period, and why that's important. That healthcare systems and facilities, including emergency, urgent care, and pediatric care settings, should have processes in place for diagnosis, referral, transfer, and treatment in cases of acute postpartum depression and postpartum psychosis. Also, that healthcare systems should ensure all providers, including those in emergency care settings, deliver comprehensive, compassionate, timely, and evidence-based care for pregnant and postpartum people with known or suspected substance use disorder or opioid use disorder, including pain management. Care should be non-judgmental, coordinated, and documented clearly. And that healthcare systems should implement, standardize, and document universal behavioral health screenings across all perinatal settings, including prenatal and postpartum visits, emergency departments, and pediatric clinics. There are a lot more recommendations throughout. It emphasizes things about keeping a birth parent and infant together and aspects like that. So the second of those broad overarching recommendations is to strengthen community support services. And by that, we mean to invest in, develop, and expand comprehensive community support services that address people's essential needs in pregnancy and postpartum. So things like strengthened home visiting programs, social work, doula support, and wraparound support for mental health and substance use disorder. A couple of the examples of the recommendations in there, things like healthcare providers connecting pregnant patients experiencing mental health conditions, substance use disorder, opioid use disorder, or other complicating factors with a harm reduction doula trained to coordinate health and social services. Health systems and facilities should integrate peer support into care teams to make it available across the perinatal continuum. This is especially important for people with co-occurring physical and behavioral health conditions. That health systems and facilities should provide universal access to social workers, nurses and caseworkers to screen parents for social determinants of health, and that the caseworkers should also help coordinate direct handoffs to specialists. And a lot of these are about providers and health systems, but there are also recommendations for the legislature around these topics as well. And then finally, the third priority recommendation to provide equitable, culturally responsive care to ensure care and services throughout pregnancy, birth, and postpartum are culturally responsive, free from bias, grounded in trauma-informed practices, and actively address racial injustice. So things like healthcare systems implementing anti-bias practices to ensure pregnant and postpartum patients receive equitable, judgment-free, and coordinated care, especially for patients disproportionately affected by perinatal mental health conditions and substance use disorder, including culturally appropriate screening tools and addressing stigma. And that healthcare systems and providers should offer compassionate, respectful care for people with substance use disorder or opioid use disorder. So things like supporting stable, nurturing parenting rather than relying on punitive measures, and ensuring treatment options and referrals are based on need and not influenced by bias. I'm happy to take any questions. I also know we've got limited time. I'm also got the contact of my colleague, Annie McHugh, who's the epidemiologist on our project here, who may actually be on this call as well, who can take, if you want to put any questions in the chat. But I encourage you to look at the full report, see some of the legislative recommendations that are relevant to you. And yeah, thank you again for your time.
Deb, I think we have a little bit of time if there are any questions. You were able to get through that pretty quickly. So if anyone has questions while Deb Cowley gets herself ready, feel free.
See the request for a copy of the PowerPoint. We can share a PDF of the slides if folks would like. Let's see. Just to bump it in the chat, here again is the link to the PDF of the report.
And we can, if folks have questions, we can of course circle back when we're ready. Oh,
Oh,
it does
question
actually
about
seem like one.
how the data were collected. I'll start this, and then Annie, I don't know if you are on the call, if you want to jump in, but these data reflect the maternal mortality review panel's process. Since I was doing a 10-minute presentation today, I didn't have time to include more information about our process, but if anybody wants a more detailed presentation where we go over things like the process, absolutely, I'm happy to talk about that. So we get records for every death in Washington State of somebody who died in pregnancy or postpartum. I have colleagues who are nurse abstractors who go through those records and produce an anonymized, de-identified short summary of the person's care and death and experience to the best that we're able to tell from all of the information. And then the panel reviews that anonymized summary and discusses it. And they start out with that question of pregnancy relatedness, like I showed in the definition. And they say, do we think this death was pregnancy related? And if so, they said, okay, do we think this death was preventable from an equity and social determinants of health perspective or a clinical perspective? And if it was preventable, what were the factors that contributed to this death? And then for each of those contributing factors, they come up with at least one recommendation, something at any level from the provider level all the way through systems change levels, whether for the legislature or other audiences, that might help prevent a death like that in the future. And then when we get ready for the report, which is about every 3 years, this past cycle varied a little bit, We go through what can be like 1,000 or more recommendations from all of those reviews over the last several years. We find what they have in common, what themes are standing out, and what are the priorities, and we distill those to be the recommendations for the report. And we also look at the data from what the panel determined in each of the reviews about which deaths were pregnancy related and which were preventable of those pregnancy related deaths. I hope that helps clarify it. And I'm putting my email in the chat again in case anybody wants to follow up with any questions.
All right. Deb Callie, do you want to get us going?
Okay, great. Well, thank you so much for having me here to present. And it's my pleasure to talk a bit about the Navigating the Perinatal Journey toolkits that Christine introduced earlier. And I am Deb Cowley. I use she, her pronouns. I am a faculty member and perinatal psychiatrist at the University of Washington from the Perk Center. I am also, let's see if I can get my slides to advance here. I am also the medical director of our state-funded perinatal psychiatry consult line for clinicians, any clinician in the state who wants to ask us about anybody they are caring for, supporting, treating, who has mental health, behavioral health problems during pregnancy or postpartum. And this includes co-occurring substance use disorders. Okay, so we have seen from my colleagues that perinatal mental health conditions are common and can have numerous adverse outcomes for the parent and for the infant. So we have heard a bit about maternal mortality, which is, a tragic outcome. There are other adverse outcomes as well. The thing that has been most studied is perinatal depression, but we know there are adverse outcomes for both the parent and for the child of a variety of perinatal mental health, behavioral health, substance use conditions. But just taking depression as an example, um, perinatal depression can cause misery, impairment in functioning, difficulty working, doing the things that you need to do, taking care of children. It can cause hospitalization and, as we have seen, suicide. There are also risks of perinatal depression, including taking worse care of yourself during pregnancy, higher rates of perinatal substance use, higher, if you're depressed during pregnancy, you're more likely to be to have postpartum depression. Depression causes difficulty bonding with the fetus and the baby. And in children, there are adverse effects like failure to thrive, developmental delay, hospitalizations, and mortality in the first year of life. It's associated with higher rates of psychiatric disorders in the child, lower verbal and full IQ scores, and increased depression risk through adolescence. So you would think, and something that is so common and has such adverse consequences, that we would be, recognizing this all the time and making sure that we treat it. In fact, this study of perinatal depression showed that it's detected about 50% of the time. Only about 15% of people receive any treatment. Only 7% receive what we would consider adequate evidence-based treatment, and only 4% are actually treated to remission, meaning that they no longer meet criteria for depression. So this is something where we can definitely improve. So how can we help people with perinatal mental health conditions? We like to think about this as a pathway. And, you would participate in this pathway depending on your role and how you interact with perinatal people. So the first step is to have universal screening, which we noticed was one of the recommendations of the report that Deb Gardner just took us through. And we know that if we don't screen everybody, then there are, for some reason, lower screening rates in people of certain racial and ethnic groups, particularly Black and Native American, American Indian populations. So we want to screen everybody. And also, people oftentimes feel shamed. They feel a lot of shame about having mental health problems or using substances during pregnancy, that this means that they're bad, that people will judge them as being a bad parent. So if we just do it universally and routinely, that takes away some of that, oh, we're focusing on you in particular about this problem. And I'll talk a little bit about how these toolkit modules help you with some of the approach to universal screening. Then there's a step of assessing, because if we screen someone and they have symptoms of depression, anxiety, um, whatever, it does not necessarily mean they have a diagnosis. They might have, psychosocial stressors, things going on in their life where they actually need another kind of support. Um, so there's a process of assessment and triage and figuring out where to refer somebody. Then there's a step of treatment and then monitoring treatment to make sure that somebody actually responds. Okay, so how can toolkits help? Why are we talking about toolkits? Well, what is a toolkit? A toolkit is a collection of resources, tools, which are very practical, action-oriented, and support this kind of pathway of support and care, and support evidence-based care. So tools in a toolkit can involve things like screening questionnaires, education or information for both providers, clinicians, and also for our clients or patients. Examples of how to talk with people about their mental health. And then things like evidence-based practice guidelines, algorithms, like what you do at each step, and checklists. So they can involve a whole variety of different kinds of things to help us move people along this care pathway. They can be integrated into electronic health records so that we are reminded to screen somebody, for example. They can support clinical decision making, make it easier to implement best practices and improve quality of care and hopefully outcomes. And they provide a sort of general information for us that we then can apply when we see individual people. Okay, so I'm going to show you some actual pages from these toolkits. So first of all, there is a module about integrating mental health into primary care. And this talks mostly about screening. So you can see here on the right-hand side, there's a page about like how you approach screening people. And it actually gives some concrete suggestions about the way in which you might talk to somebody about this. So the first one, while I'm not expecting any particular issues with you or your pregnancy, I'd just like to briefly discuss mental health. It's common for women to develop concerns or anxieties about what can be a difficult stage in their life, dealing with pregnancy, childbirth, coping with a newborn baby. It's important to understand that these concerns are nothing to be ashamed of, and we can provide lots of help and support. So this does a couple of things. It normalizes it, like these are common things. Um, you're not the only person. And also that it explicitly states that it's nothing to be ashamed of. The second example, and you can see there are two examples here, but of course you can kind of modify this for your situation or how you feel comfortable talking to people. The second example, pregnancy, childbirth, and looking after a newborn baby can be a difficult time in a woman's life. It's common for people to feel anxious, low in mood, and they may hide these feelings for fear of seeming like they can't cope. But we can discuss anything here, and I'd like to help whenever possible. So tell me, how have you been feeling recently? And this can introduce the topic of mental health, behavioral health, and then set the stage for screening. So the screening tools that are in this toolkit include perinatal depression screening tools that you may be familiar with, the EPDS, the PHQ-9. They talk about how to score it, um, cutoffs for mild, moderate, severe. They give URLs or QR codes for accessing screening tools. There are screening tools for anxiety, the perinatal anxiety screening scale, and the GAD-2 or 7. And they talk about an interpersonal violence screening tool and a substance use screening tool, the modified 5Ps. So there are some other modules, other toolkits within this collection that focus on specific issues like anxiety, sleep, ADHD. So I'm just going to show you some examples of the perinatal anxiety toolkit, primarily, just to kind of walk you through like what is in these toolkits. So the perinatal anxiety toolkit, you can see here, it talks about like how common this is. It talks about things that might predispose someone to having anxiety during the perinatal period. It talks about health disparities that Hispanic and non-Hispanic Black women, people report higher levels of stress and anxiety during pregnancy. Talks about indigenous populations, and that women of color are, like we were talking about earlier, are for some reason less likely to be screened, diagnosed, and receive treatment. And then it talks about consequences. So earlier we talked about potential adverse consequences of perinatal depression. So this goes through some of the potential adverse consequences of perinatal anxiety, like hypertension, increased blood pressure during pregnancy, preterm birth, low birth weight, um, difficulties bonding, as with depression, lower likelihood of initiating and continuing breastfeeding, postpartum depression, and in the child, emotional difficulties, behavior problems, and symptoms and disorders later on. And so there's a part within each like diagnostic or clinical problem focused module that talks about screening. So here with anxiety, it talks about when to screen at the initial prenatal visit, each trimester, and then postpartum. And again, it gives an example of how you might approach this. We screen all of our patients for anxiety because mental health changes and concerns are so common during pregnancy. These forms don't diagnose you with a mental health condition, but they help us to talk with you about the best way to support you. So again, it's that kind of normalizing, and that these are issues that we can help with. And then the screening tools are here again with links, with QR codes, and talks about the different kind of scoring. The anxiety toolkit then discusses symptoms. So if somebody is reporting anxiety on a screening tool, this is sort of goes over some of the symptoms or thoughts that they might be having. Psychological symptoms, common worry themes, physical symptoms. It shows some examples of things that people might worry about the pregnancy or the baby, What if my baby stops breathing while they're sleeping? I feel like I need to check on them constantly to make sure they're okay. What if I accidentally do something to harm my unborn baby while I'm pregnant? So lots of worries that people might have during pregnancy and taking care of a newborn baby. There's a little section about how to tell perinatal anxiety, like something that is clinically concerning from like normal worry, because having some degree of anxiety or worry is kind of normal in pregnancy. It's having a newborn baby, especially if it's your first, it's kind of an out of control situation in many ways and involves new skills. Um, and then there's a little section at the bottom here on the right about how to make a diagnosis. And again, you might be looking at situational causes where someone needs more social support, more basic needs kind of resources, as opposed to things that, anxiety that's really like associated with an anxiety disorder or another psychiatric disorder or with substance use. Another part of this set of toolkits there's a part about safety, goes over things like intrusive thoughts and suicidal thoughts. So the really important challenge of how you tell, for example, if someone has thoughts about harming their baby, are these things that the thoughts that they are horrified about? Are they things that, really demonstrate the possibility of psychosis? Things about suicidal thoughts and how to assess suicidal thoughts. And then just following on this example of perinatal anxiety, the toolkit goes over treatment. Pharmacologic treatment, treatment with medication is not really stressed in these toolkits. There are some general guidelines here for prescribing during pregnancy. Use what's previously worked, minimize the number of medications, that kind of thing. Um, but there is a reference actually to our Perk Center perinatal anxiety guide, which I'll just show you in a moment, for specifics of medication if you are prescribing medication. And then other treatments, psychotherapy, other treatments such as maximizing sleep, which really helps to prevent or treat anxiety and depression during the perinatal period, physical activity, yoga, massage, relaxation exercises. And there's a treatment algorithm. So this is kind of like a step by step. You screen, you find a certain degree of anxiety. What do you do next? So a toolkit, again, can be really helpful in guiding you through the steps of what to do, depending on your scope of practice and situation. So at the Perk Center, we do have a perinatal mental health care guide with a variety of modules that cover, a lot of psychiatric conditions and substance use. And I'm just going to show you an example of a medication table. So if you're prescribing medications, these tables can be helpful. They talk about specific medications, how you prescribe them, like what the starting dose is, how you increase the dose, side effects. So all of those are not actually related to pregnancy or postpartum, but are just general things about these medications, and then use in pregnancy and use during lactation. Okay, so actually, um, that's the end of what I wanted to show you about the toolkits. And in summary, as we've seen, perinatal mental health conditions and substance use are common. They're associated with significant adverse parent and child outcomes, and they often go unrecognized and untreated. So toolkits can be one thing that helps us to help our clients or patients through making sure that we are screening them to see if they might have these kinds of issues during pregnancy and postpartum, identifying the need for further assessment and diagnosis, providing examples. I think some of these toolkits have really nice ways, examples of how to talk to somebody about mental health concerns, um, and providing information and algorithms for treatment. And these are meant to be, sources of general information and guidance for evidence-based care. Every person that we see is different. So, parts of a toolkit might apply to someone, be relevant for our being able to help and support them, and some might not be so relevant, but these toolkits can provide a starting point. And they can also be good in your healthcare system, as we discussed, to make sure that people are being screened, that we pick up people who have behavioral health conditions. Okay, so that is actually all that I had to discuss. And Christine, I don't know whether you wanted to talk about resources here or if
I
people have
am happy to
questions.
try to do some cover these, and then maybe we can pause for people to have questions. Um, Deb obviously did a great job already kind of sharing about the toolkits. I'm wondering, so there's actually folks here who are connected to these initiatives, and so I'm
Mhm.
totally putting you all on the spot, and so you can totally say no. But I'm wondering if Victoria, would you be comfortable talking about Perinatal Support Washington? And Lark, then we could hand over to you, and then Deb, I can go to you and Amrita.
Sure, shall I just jump in?
Awesome. Thanks, Victoria.
Get me off if you need me to. So I'm Victoria, and I'm the Senior Warm Line Program Manager at Perinatal Support Washington. And we have a peer support warm line. It covers the entire state. We have, and peer, of course, means that our staff, interns, and volunteers are parents with lived experience of a perinatal mental health condition and are on the other side. And we know peer support is evidence-based. People get into treatment faster. They feel less guilt and shame, and that is exactly what we do on the line. We provide targeted referrals, so we don't give out names to therapists unless we know that they have take the insurance and have openings. So we actually do a lot of the legwork for parents, and then we just offer a lot of emotional support because as Deb was alluding to, parents don't feel safe talking about it. And so talking to another parent really reduces that barrier a lot faster for them to really open up about what's going on. So we offer a lot of emotional support while they're waiting to get in with a therapist or into treatment. We might do some wellness planning with them if they want. And we're more than one call because we know that this is such a vital time period. So we are at least a week-long service, and if they want to, we continue further with the same peer and kind of a mentorship role. So that's the quick gist.
Thanks, Victoria. And I think we have Lark here who could share a little bit about Help Me Grow.
Yeah, happy to. Thank you for the opportunity. And we collaborate a lot with everyone that you see here on this slide. We do a lot of warm connections between Perinatal Support of Washington and Perinatal PCL. And so Help Me Grow Washington is a resource and referral support for prenatal through age 5 children and all the people who hold aspirations and relationships with those children. And so we provide support in the areas of connecting around food and nutrition, health, including pediatric supports, behavioral mental health support. We also provide support as far as enrollment in health insurance. Back on the food piece, we also can provide support in relation to application for basic food. We can do supported assistance with that. Our other two areas of focus are family stability. That can be everything from finding concrete goods in your local community to transportation assistance And then our final area is development, and we're able to provide support around ages and stages, child developmental screening, and then getting connected to early supports in your local community. That's kind of our areas, and really happy to be in this space and be with thought partners, thinking about how we can support people in that perinatal period.
Thanks so much, Lark. I'm wondering if our dear friend Amritha would mind talking about the Perk Center and perinatal PCL.
Sure, happy to.
Thanks,
Hi
Amritha.
everyone, I'm Amrita Bhatt. I'm a perinatal psychiatrist and I direct our PERC Center and I'm the co-medical director of the perinatal PCL. So our PERC Center, the University of Washington, is focused on increasing access to perinatal mental health and SUD treatment through direct clinical consultation, consultation for providers, workforce development, and research and implementation. Um, so Dr. Cowley already described our perinatal PCL, which is state-funded um, provider-to-provider consultation line for anyone across Washington state that has questions about their patients pertaining to their mental health or SUD during their reproductive journey. We also have Moms Access Project ECHO, which is a monthly case conferenced didactic and case discussion series. And we have various clinic support implementation projects to support clinics in developing their screening and treatment workflows. So that's just a tiny summary of what we do, and I'll put a link in the chat to our PERC Center services.
Thanks so much, Amritha. And then for Washington State Perinatal Collaborative, I think Tiffany Tibbs is here and might be able to share a little bit about that.
Hi, Christine. Hi, everyone. Yes, I'm happy to share about the Washington State Perinatal Collaborative. I can turn on my video too. So the WSPC, this is a volunteer group of a lot of different folks. We've got public and private agencies, state organizations, community members, healthcare providers, and really one of our main goals is to implement the recommendations from the Maternal Mortality Review Panel. And so there are a number of projects that we are either leading or that we are supporting. Some of our priority areas include mental health, perinatal substance use disorder. We also have community supports. We have obstetric care. We have expanding access to rural care. So there's a lot of things that we're working on and that we're involved in. And we're always looking to expand our partnership and our collaboration with folks. So I'm happy to drop my contact information in the chat as well as the WSPC webpage and a link to our newsletter. Thank you.
Thanks, Tiffany. So that is what we have for today. I did see a question in the chat that I think Amritha has already spoken to, but I don't know if Deb or Amritha, if you have more you want to share. Alma had just asked about what happens if a postpartum person is not attending their postpartum medical appointments and how they'll be screened. And so is there anything else that you would want to add to that, Amritha or Deb, anything you want to share?
Well, first of all, I'd like just to say that, we have an opportunity during pregnancy and postpartum. People actually, go to visits in healthcare systems more than they usually would, as like young adults. So, in a way, there are more opportunities to screen and intervene and help people. On the other hand, as the question illustrates, yes, I mean, oftentimes people don't go to postpartum visits. They may go to visits for their child, child visits, because a lot of us, will do things for our children that maybe we would not do for ourselves. So it's very important also to screen in pediatric settings, but there are also some community settings. And Amrita, you had mentioned this in the chat. I don't know if you wanted to add anything else about that.
Sure, there are, and this question of screening in the postpartum period is so important, especially in the context of the data that Debs presented earlier from the Maternal Mortality Review Panel findings that a majority of the behavioral health related deaths were in the late postpartum period. So in addition to pediatric well child visits, home visits with public health nurses or early childhood development specialists are other venues in which people can be screened. And I also know some doula programs, for example, that screen during pregnancy and postpartum. And then this, of course, calls for more coordination between healthcare and community-based systems.
Thanks, Amrita. Alicia, I know you answered in the chat. Is there anything you want to add? I know you came on camera, and then I can get to the next question.
Yeah, I love that folks are getting screened in the medical systems and in home visits and all of those things. And I mean, clearly my agency does all of those things, but I would venture to say that there's actually a huge opportunity for us to add screening in far more non-traditional settings. And I would wonder if those screenings would actually be more effective. I mean, once somebody goes into the medical system, we already know that there's power dynamics at play, and there's really interesting, concerns about whether people are, going to be reported to child welfare or, what happens in all of those places. So I would love to see a place where folks who run play groups, folks who run support groups, folks who run, the MOPS group or the PEPS groups, or all of these really, really non-traditional places where moms hang out, are able to screen or at least have screenings available and know what to do with that, because those are the places that people feel safe enough that they can say the real thing. And I think that's where some of this really transformational change will actually happen rather than in the medical clinic. I think should potentially even be the secondary screening after they said the whole truth in a different place.
Getting lots of hearts and I think affirmations of agreement. So thank you. I also saw a question from Delta, and Delta, it's a great question about using the term women. I think I will just speak for myself, and I invite my friends from other parts at the different state agencies and at the Perk Center. We are moving towards using the term perinatal people and individuals, and these toolkits were modified from North Carolina, and you are highlighting that we probably missed some of those changes that we were making throughout the guides. And so I know that the Healthcare Authority is making efforts to use the term like perinatal people or individuals and things like that. And it is likely just an editorial that we are a work in progress. But I don't know if Deb or if you have thoughts, or either Deb, in terms of terminology that you all are using in your work.
Well, I mean, actually, we tend to use terms like perinatal people or individuals. And as I was reading some of those things from the toolkits, I was thinking, that's yeah, like you say, it's an editorial thing that we should correct, and appreciate the comment.
Yeah, and I will just add that some of the places where women are mentioned is reflective of the fact that unfortunately research in this area has focused on women, cisgender women, and there's not a lot of research on gender diverse individuals in the perinatal period. And so when we are citing certain research studies that were conducted on only women, that's the place that we use the term women.
Thanks, Deb and Amrita. We have about 5 more minutes left today. If folks have questions, as we start to wrap up, please feel free to put things in the chat. I just want to give a huge shout out and thank you to our presenters today.